Tay here from the Pacific Islander Health Board of Washington. Omri's here as well. Today we have a very special guest, as always, for our talk story to talk about reproductive health. Today our guest name, you're welcome, buddy. Today our guest name is Arya. Oh my gosh, we just
Arya Pretlow.
Arya, thank you. I'm so sorry.
That's okay. I get it all the time.
A trigger warning to anyone who is watching this talk story today. We will be getting real and raw, no pun intended. This will be very educational, so it would be helpful if you maybe take notes or screenshot the conversation as we go. There has been a lovely presentation that has been prepared for us, and I'll go ahead and let you take the floor away.
Thank you. Thank you so much. I'm so delighted to be here and so honored to have been invited to give this talk. I have a slideshow, and as much as I love this beautiful picture of a flowery uterus, I think Netta has the slideshow. Okay, we're ready.
Hi, Esther. Esther is joining us today too. She's the perinatal manager at BSK, in our BSK team.
So the title of the talk this evening is Reproductive Healthcare and You. By me, there's a lot of letters after my name. It has to do with the education to become a nurse midwife. I'm also an international board certified lactation consultant, which is a whole other specialty, and a certified yoga therapist. And I practice in the Rainier Valley Birth and Health Center, which many of you may know as Rainier Valley Midwives, or RVM. It started out as RVM, and we're growing our practice, and so we've adjusted the name. Slide, please.
Netta, you can go next.
So my name, as I said, is Arya Pretlow. You're going to see me look to the side a little bit because I have notes for myself to make sure I cover everything. My pronouns are she, her. I identify as a cisgender heterosexual woman of mixed Celtic European descent, and I'm a certified nurse midwife. This is a specialty of advanced registered nurse practitioners whose scope includes anyone who identifies as female or who was born with female reproductive parts from adolescence through the end of life. So people tend to think of, they hear midwife and they're like, oh, you just do babies, like pregnancy. And actually, in addition to prenatal care, labor, birth, postpartum care, a certified nurse midwife is also a primary care provider. And so we just happen to specialize in what we're just going to call women's healthcare. But I also help people with chronic conditions, not at all related to their reproductive parts, with behavioral health concerns, all kinds of things. I'd like to acknowledge throughout this talk, I will say women's healthcare, but trans people are included. The people who are outside of my scope is really just babies older than 4 weeks. So I can take care of a gestational parent in the early postpartum, and then, forever. And their new baby. And then children before puberty are outside of my scope, and men who were born with male reproductive parts are outside of my scope. And you may notice during the talk that I say client instead of patient, and that is a conscious choice in an effort to dismantle the power dynamic of the traditional doctor-patient relationship. I want my clients to feel as powerful as I believe them to be, and helping them not feel like quote unquote sick people is part of that. So if you're wondering what a nurse practitioner is, it's like, okay, so a CNM is a kind of nurse practitioner, but what does that even mean? you are not the only one. I spend a lot of time educating about what my job what my job is. So we are master's or doctoral prepared registered nurses. So we did a Bachelor of Science in Nursing. We took the licensing exam to be a nurse. Most of us worked for some amount of time, usually as bedside nurses, which means we were in the hospital taking care of business for those long, hungry shifts, and decided that we wanted to expand our scope. And so there's a range of specialties. There are nurse practitioners who are work in oncology or pediatrics or pediatric oncology. There's anesthetists who, you know, are back in surgery helping the anesthesiologist and oftentimes running anesthesia during surgeries. There's just all kinds of nurse practitioners, all kinds of ways to do this job. The thing that we all have in common is the nursing model of care. And so this is a holistic approach to healthcare that considers not just the symptoms of someone who comes to me and says, I'm so sick, I have this, this, and this. I want to help you with those symptoms. And I want to take a holistic approach and recognize that there's more going on than just those symptoms. Were you run down? What's going on in your life that got you run down? Are you undernourished? What's going on that you don't either have access to food or time to prepare the food or time to eat the food? So we want to look at like the bigger, all the things that are impacting a person's health and wellness, which could be everything from, you know, what they're taking into their body to their living environment, and then in the bigger picture to systemic issues. So this brings us into a really good time for me to acknowledge that a big part of my work as a white provider and a heteronormative cisgender person is to recognize that much of my work is to walk into my room and give all the power to the client, right? Like, this isn't me telling you how to live your life and how to fix your sore throat or whatever else the case may be.
Mhm.
This is like, how can I be of service? I'm here to help. I have this passion and this education and this experience, and I'm here to, you know, offering it for you to utilize in a way that feels appropriate for you. So nurses look at all of that. And then, of course, preventive care is a really big part in the nursing model of care for sure, because if we can prevent the illness, that's way better than trying to help people clean up.
Mhm.
So reproductive health is important for a lot of reasons. I lost the slides. Did they come off your screen also?
They did. While Netta is getting that back up, I do
Yeah.
have a question.
Okay.
Where can CNMs be found doing their work? Is it
Ooh.
in hospitals or?
Yes. Okay. So everywhere. A lot of certified nurse midwives do work in a hospital setting because the reality in America still is that most people have their baby in the hospital. And so from a midwifery perspective, if we are the experts, licensed midwives, certified nurse midwives, in states where there are licensed midwives, but there's no license, so they're just called
Mhm.
direct entry midwives. We are the experts on normal, low risk pregnancy and birth. We send people who risk out of that category to the specialists of problems in pregnancy, right? So like, ooh, you've developed hypertension, that puts you at risk for possible seizures. Having your baby outside of the hospital is not appropriate for the safety of yourself or your baby, and so we send people into the hospital. In the hospital then are nurse midwives who we can maintain that care. We can still give you as close to a physiologic, meaning just let nature take its course, birth experience as possible in the setting of the hospital, and providing you with the medication or whatever intervention is needed to help you do it as safely as possible. So even nurse midwives who are in a hospital setting still have lower cesarean rates, lower rates of tears, lower rates of intervention, because we still follow the midwifery model of care of birth is a normal process until or unless it proves itself not to be, right? Like until we're watching and something is like, something's not working, then that's that. So a lot of us are and a lot of us become nurse midwives because we're all about the babies, right? We're like, yay! It is magical to have, like, to be the first person helping this other little person out into the air, right? That transition is stunning and impactful. And like, I get teary just thinking about it, even though I choose not to catch babies anymore because I like sleeping. And I don't I don't like being on call. And
Yeah.
so, um, some of us really only do prenatal postpartum care and like gyne visits, right? Like I'm just here for my pelvic exam, I'm here for contraception, I'm here because I have a discharge or an itch or whatever. Um, and then others of us, like myself, focus on all of the primary care. Like, what if I can take this midwifery model of care, this approach that many of the things that we are experiencing are just part of being human and we don't have to catastrophize, then what if I sit with you and spend an hour with you and learn about you and your life, and we develop a relationship with that same goal of wellness in this case. Um, and so some of us can be found in primary care offices. Some of us may be in private practice. Some of us also, like myself, are in a collaborative practice with licensed midwives. What happens in our clinic is the baby catching and the prenatal care is still the realm of the licensed midwives. And so our clients, most of them are planning an out of hospital birth. Sometimes people want to have a hospital birth, but they want midwifery care with us, which is fine. We can set it up so you can have your care with us, and then the actual welcoming of the baby is planned for in the hospital, and we help with that transfer. Um, but then let's say someone gets a urinary tract infection. Well, if you're pregnant, it's really important that a urinary tract infection be treated because it can very quickly become a kidney infection, and that can very quickly cause preterm labor and all manner of awful things. So the sooner we treat a bladder infection, a urinary tract infection, the better. But the licensed midwives, it is not in their scope to diagnose or to prescribe.
Mm.
Right? And so it's not rocket science to see that someone has a urinary tract infection. It's like it burns when I pee. I can't hold it very long, and I have to pee so frequently, even for a pregnant person. And like, okay, that's a urinary tract infection. But it isn't in their scope to actually diagnose it. It is in mine. So my dream job was what I'm doing now. I trained initially as a licensed midwife. I just wanted to catch babies and hang out in people's homes while they were in labor and support them and reassure them, and then be like, you did the thing, yay, and like manage anything that came up. And then life takes its twists and turns, and I moved somewhere where that wasn't really an option. And so I had to go to nursing school and be a nurse midwife in order to stay in my field and keep doing this work. So for me, a lot of my focus, I do love the babies, the squishy little brand new little babies. And also what I always felt passionate about was supporting choices in care for clients. I think you should be able to choose to have a birth at home or in the hospital or in the birth center. It's wherever you feel safest and most powerful is with appropriate support. I'm not in support of just having a baby at home by yourself, because it can be difficult to access emergency care in those situations. But with a trained professional there to support you, it's a wonderful option that I wanted to help protect for people. And now as a nurse midwife, I get to do that in a way that helps not only my licensed midwife colleagues who are like, Arya, I'm sending her down the hall. It's virtual. I'm sending her down the hall. I put this person on your schedule. I think they're depressed and they need to talk to someone who maybe can actually diagnose. And I don't start with medications by any means, but I at least have the option of including medications if the person wants them. Urinary tract infections, the ones from pregnancy, I get a lot of yeast infection, bacterial vaginosis, people who need medication. So if someone has herpes, if you have genital herpes, it is an indication for a cesarean section. If you have sores on your vulva, or inside the vagina, anywhere where the baby will touch, it's an indication to not even try a vaginal delivery. And so when people have that virus just living in them, you can't plan when you'll have an outbreak. And so the recommendation, the standard of care is prophylactic antivirals that we start later in pregnancy. Well, I can write that prescription, right? So we just have all of that lined up to make it so that clients don't have to like go to urgent care, right? Like I got a UTI, I'm 30 weeks pregnant, COVID days, I don't want to go hang out in urgent care, right? Not if I don't have to. And it can be hard to get into whoever your regular provider might be, but in our practice, they can just set up a telehealth with me, or if it's something I need to put my hands on them in order to diagnose, then we just slip them on my schedule whenever we can. And then you'll find nurse midwives in Planned Parenthood. You'll find them just all in fertility clinics, doing research, teaching. I also teach at Bastry. There's all kinds of things that we do.
So when you said everywhere,
Yeah,
you
really.
really meant everywhere.
Yeah. And some of us do a lot of outreach. So there are people who will do, it's kind of like Doctors Without Borders. There are similar kinds of programs for midwives in particular. God, their midwives are needed in so many parts of the world. So some people will also just be kind of a traveling midwife and just go where people seem to need us the most. Yeah.
That's beautiful.
So a lot of what we do for the community at Rainier Valley Birth and Health Center is bringing the care that has been shown to provide the most benefit to some populations that are really underserved and under-resourced. And so, that yes, we take Melina, right? Like, yes, we take Apple Care. And we have a variety of programs so we have something called the Birth Bundle Project. It includes having a doula, having lactation support, having a prenatal lactation assessment, because it's really unfortunate to find out that, maybe because of some underlying condition, you need to adjust your goals for breastfeeding your baby, right? Like you might be able to breastfeed some, but maybe there's something going on that we could identify prenatally that makes it so it's not likely that will be the only source of nutrients for your baby. So these are things that are really important so that people don't have so many surprises.
That's true. Surprises are no fun, especially during pregnancy.
Yeah.
Thank you. That was a really good explanation. I'm sure anyone who's watching will have a very good in-depth understanding of what CNMs do and where you can find them. So
Good. Okay. Okay, so next slide. So what is reproductive health care? Generally, what we're talking about is also called women's health. And as I said previously, in our scope of a certified nurse midwife, that includes trans people. So anything that includes the reproductive organs and related conditions. So again, my scope is primary care, but a lot of time if you go to a place that's like just a CNM clinic, it's often people aren't thinking, I have an ear infection, I'm gonna go see my midwife. They're thinking, I think I might have a yeast infection, I'm going to go see my midwife.
Mhm.
So if we focus that from primary care down into reproductive health care, we really are looking at things that are about like something's going on with the hormones. So that could be, PMS, super bad cramps, painful breasts. It could be acne flares. It could be so many things. It can be in adolescence. It could be like, why aren't my breasts growing yet? Or why are they growing asymmetric? Like, why is one so big and the other one's not growing? What's going on? It could be anything related to the menstrual cycle. It's so heavy. It's irregular. Polycystic ovary syndrome. Any contraception needs. We do not have to do a pelvic exam. I'm going to say it again for the people in the back. We do not have to do a pelvic exam in order for you to get contraception. I can do that in a telehealth, right? Like I need some history, I need some information, but I do not have to put my hands inside your body. Period. Dot. When I was a youth, that was the barrier, right? Teenagers were not really able to access reliable contraception because that meant having to go and get a pelvic exam. And then how are we supposed to explain that to anybody or pay for it? Now, not only is your privacy assured in that your parent doesn't get to come into this appointment with you, I cannot and will not share anything that we discuss as long as it isn't about something abusive, like your life is in danger because you're being abused. That's different. We all have reporting requirements in healthcare, but it's about that. It's not about like, I just want you to know I saw your daughter today. Like, no, there are laws against that. That's not appropriate. So contraception, family planning and child spacing, I put that separate from contraception because it's related, but also, sometimes it's really just learning about like, oh, I could, there are measures that I could take to space out my children in a way that actually can help me feel healthier and have a little more energy and meet the needs of my family. Fertility and preconception, I see a lot of people who are either having trouble conceiving or they just have seen a lot of people have trouble conceiving and they're thinking they might want to start trying to conceive soon. And they want to just talk about like, how can they improve their chances of conceiving? And like be as healthy as possible before they actually conceive. Pregnancy, birth, and postpartum care, of course. I don't specifically do those things. So one of the things that happens in obstetric care, no matter who the provider is your malpractice insurance is way higher if you take care of pregnant people or catch babies. And we decided, since I wanted to really focus on primary care, that we would just get a different insurance. So I see people who happen to be pregnant, but I'm not the one measuring their bellies and listening to their babies and all those things. I am helping with whatever acute condition is happening. Perimenopause care. So here's an area that people are finally speaking up about and really demanding research, evidence-based treatments, and a rethinking of how we help people navigate the perimenopause change. The bottom line for that, I don't know the age group of the audience necessarily, but the bottom line for that is you do not need to suffer. Please call me. There's a lot that can be done to help. Of course, we're screening for diseases. So in reproductive health care, it tends to focus on the reproductive organs, like, screening for STIs. And that could be like from your urine, from a vaginal swab, from your blood. I will also say, you gave the trigger warning. The swab might not only need to be your vagina, depending on where you are putting other people's parts, right? And so sometimes we need to swab a throat. Sometimes we need to swab an anus. To help identify what is going on for someone if those are areas that they are engaging in sexual activity. And then other infections that are not of a sexual nature but happen in the reproductive organs, like a yeast infection, like bacterial vaginosis. And then, of course, cancers. In this case, for reproductive health, we are certainly focused on the ones people are going to probably be most familiar with is breast cancer, cervical cancer, uterine cancer, and ovarian cancer. There are you can get cancer anywhere, but that's generally what we're like screening for when we're thinking of reproductive health care. And then another one that, again, I will say it as many times as it needs to be said, is pleasure. We are talking about sexuality, and especially for those of us with female reproductive parts, we literally have an organ that's only job is to feel good. That's the clitoris. That's not for nothing, right? And also, most women have never had an orgasm.
Wow.
There needs to be some education about why that is. There's nothing wrong with them, but you have to actually know what to do with your clitoris, right? It's about understanding what works for, like, who you're having sex with, and are their parts doing what needs to be done for your parts in order for it to feel good. And so along with that also comes, like, is sex painful? Are people libido, especially different stages of life, even just postpartum, because of the hormone changes, you have less estrogen. Maybe you're busy breastfeeding and you're just touched out, we say, like, I just don't want another person needing something from my body.
Yes.
Right? Like, there's little paws on me all the time. But also that lower estrogen state, which helps you hopefully not make another baby while you're trying to breastfeed and keep this one alive. Thank you, Mother Nature. It decreases the hold on, it's going to come to me. Late in the day, I start being like, what is the word? So not only the available lubrication that your body makes, but also even just like the plumpness and sort of, for lack of a better term, kind of juiciness
Mm-hmm.
of the vaginal mucosa, so which helps make sex more comfortable. And
Right.
so sometimes people are like, I'm ready, I want to again, but it's uncomfortable. So if sex is uncomfortable, it's very common to not want to do it. But the problem isn't that you don't want sex. The problem is that sex is hurting. And so we can also help with that. That's very much a part of reproductive health care. In my work, that's just part of my intake when I'm going through, like, especially if it's just kind of a gyne visit, they're here for a pelvic exam, they're due for their pap smear, whatever. That's one of the things is like, are you satisfied with your sexual experiences right now? How's your libido? Do you have pain? And do you have any concerns? And a lot of people have never been asked those basic things. They've been, they could be in their 30s. They've been seeing people for these kinds of exams their whole life, having sex for decades, right? And they're like, no one's ever bothered to ask me these things. But it matters. It's a basic part of human health. So, next slide, please.
Before, as you get ready. Okay.
You're back.
As you get ready to talk about your next subject or move further into your slides, community, I just want you all to know that we are in community. We're asking young women and pregnant people what it is that they need educationally for right now for their bodies. And this is something that has been asked for. So as we move through, keep an open mind. Listen to the information that's being given and digest it for what she's saying, and try to see it beyond being uncomfortable if it may get uncomfortable for you, because this is good information, and we're not saying go have sex, everybody just go have sex, and nothing like that. It's more education for our bodies and to learn what's going on. And this is what you've been asking for. So as we continue, just everybody keep that in mind for me. And I'm going to make sure this phone is off.
I'll wait till she gets back to talk about this slide. I see your comment, Stacy Haney. Thank you. Stacy Haney is my former boss. So fun.
Thanks for joining us,
I'm
Stacy.
delighted she's watching. That's fun. Okay, so why is reproductive health important? Oh my goodness. So the first thing that I think of is overall quality of life. And anyone who has ever had painful periods, I feel like you get this, right?
Mhm.
If you are missing work or school or even just literally anything because your period is so heavy on the first day or two, or the cramps are so bad, or you're just laid out, you can't with life, that doesn't have to be that way. That's not the price we pay for having the ability to conceive. That's there are things that we can do on a variety of levels to help make periods more manageable. So other things, quality of life, I think I already touched on, like painful sex, right? If that's a basic part of, um, let's say in a marital relationship, there's generally certain expectations between partners. And again, if it hurts, it impacts your quality of life and possibly the relationship. Premenstrual syndrome. Yes, right. Getting pregnant when you don't want to be pregnant, or not being able to get pregnant when you do want to get pregnant. Both of those things have a huge impact on your quality of life. And then protection of fertility. So there are sexually transmitted diseases that you may not have any symptoms, such as chlamydia. And while you are not knowing that you have this, it is silently injuring your fallopian tubes, your uterine tubes, which is what the little egg from the ovary has to
Mhm.
travel through in order to be able to meet up with the sperm and become a little embryo and implant in your uterus. If the egg can't get through that tube, you cannot get pregnant via that form. You have to use reproductive technology. There are lots of ways to make a baby. It doesn't have to be the old-fashioned way, we might say, right? There's all manner of ways, intrauterine insemination and in vitro fertilization, lots of things, lots of ways to help. But if you have had an injury to your tubes because you didn't know to get screened for STIs, for example, that can injure, your goals for how you make a family. Um, let's see, timing of pregnancies. So the World Health Organization recommends 18 to 24 months between having a baby and conceiving the next one. Not having the next one, conceiving the next one.
Mhm.
Now, we like to say that pregnancy is 9 months. It is not 9 months. I don't know why the math is so hard. It's it's an average of 40 weeks. That's not 9 months. So if we say, let's just say 10, make it closer to a year, let's round up to a year. Right? So when people space that this way, so you let your body replenish its calcium, replenish all its nutrients, replenish your energy, for crying out loud. Maybe that first baby is weaned or is weaning by this time, maybe. You're starting to kind of have a little sense of this little baby. The older baby is a little bit, now they're toddling and able to do things and be entertained by more things. And okay, I got a little something to give to a new baby. It's a good time to make one. So that child spacing is really important. And then understanding your options for contraception is part of that. And that could be everything. I mean, I hear the gambit, and I always just come back to how critical is it for you, client, to not get pregnant during this time? Because that should have some impact on your choice for how you manage your fertility while if it's like, oh no, I cannot do that again right now. Then there's very wonderful and reversible options for contraception that can help you reach that goal. And I have people who are like, I mean, it's not the end of the world. Like, I don't want to have my baby too close together, but eh, I'm like, okay, then your plan to just use what's called lactational amenorrhea is probably fine.
Yeah.
Okay. And then screening. So we don't only screen for STIs, but also other illnesses. I talked about that a little bit. And then chronic conditions like diabetes or hypertension, thyroid problems. And so when you come in, because oftentimes a reproductive health appointment is the only regular health care that a woman gets. Oftentimes they don't have a primary care provider. They're like, I mean, this is my gynecologist. So who do you see if you have whatever. If you have the flu, I just go to urgent care, right? So when you come for just a gyne appointment, we're trying to fit in a whole bunch of things. Do you need a flu vaccine? Do you need, do you need this? Do you need that? Do you want to be screened for this or that? Because you're here and we have all of these things we can offer you. Let's see. Yeah. Any questions about those?
Let's see. I'm not seeing any in the chat. I think we're good to move on.
Okay. Next slide, please. Okay, so the common reproductive concerns, these are the ones that I see a lot of is, so it keeps coming up, is the painful periods, heavy periods, and PMS. Oftentimes there's a combination of things. It's what's going on stress-wise for the person, what's going on nutrition-wise, hydration, like just basic care and feeding of the human body impacts this really basic function. We also know that there's some relationship, like not just with stress, like a great deal of stress can make you miss a period because it makes you not ovulate. And if you don't ovulate, you skip a period. And that could be anything from like I got rear-ended to I was in an earthquake, right? It could be any kind of stress if it happens in the first part of your cycle. So between the first day of bleeding and when you ovulate, then that stress can be enough to throw your hormones off just enough to tell your body now is not a good time to make a baby. And so it won't let the things that need to happen for that egg to come out don't happen. And so then you have a late period or you don't, or you skip that month. So prevention of those things and treatment of those things, the painful periods, heavy periods, PMS, is multifaceted, I would say, and very individual. Sometimes people just need a little bit of like a combined hormone birth control pill, right? An estrogen and progestin birth control pill can be enough to just manage the hormones to make it even out a little bit. And then you don't have to stay on it if you don't want to. But if we just think of it, you can think of what we commonly call contraceptive pills. It's just hormones, and we use them for all kinds of things, not just to manage fertility, but sometimes it is the medicine needed to manage the painful periods or the heavy periods, or also the menopause transition when sometimes people bleed way too much. Fertility management, low fertility, again, contraception, that's always a big one, and trying to conceive. I think the biggest thing, and I see here a comment about the information and how important it can be for the partners to understand. One of the things that I wish people learned in whatever version of sex ed they maybe or maybe didn't have in high school or whenever, is what is actually happening in your whole menstrual cycle and all the signs your body gives you to tell you this is when I would very much be willing to make a baby. This is certain hormones going up. I do a lot of hand signals, right? So when you're coming up to ovulate, you can get pregnant even if you have exposure to sperm. However it happens, you have exposure to sperm inside your uterus. It swims up and it can live inside of you for a couple of days, and it can meet that egg as soon as it pops out and be like, now we're talking about millions of sperm, not a sperm that's up there, but it's really just one egg. And so your signs, your body, if you're in your childbearing years, let's take out all of the modern nuance of like modern living, your body just wants to make babies. That like your body is like, "Hey, I'm about to release an egg, and I think it would be awesome if you would go find someone to expose yourself to sperm with," right? So that's when we have increased interest in sex. That's when we have increased vaginal discharge. Sometimes people mistake that for an infection, but it's actually your body's way of like lubing up and making it very easy for the sperm to get up inside of you where it needs to be to meet that egg. These are normal changes, and if you're not wanting to conceive, it's very annoying that that when you most are interested in having the sex is also when you're like, "Darn it, but I don't."
Yeah.
So you but recognizing those signs of your fertile phase can also help you know, like, how important is it to me to not get pregnant? And so what can I do, and what can my partner do to help us prevent that, even if we still want to have sex? And so sometimes, and on the other side of the coin is, hey, I'm entering my fertile phase. Let's make sure we get some time together because we're trying to conceive. But
Mm.
I see people all the time who are like, I've been trying for months. And I'm like, well, what's your cycle like? And they know when they have their periods, but they don't know when they're fertile. And so they're not even having sex at the time. I mean, you can have sex whenever you want to, but you're most likely to conceive and you're highly unlikely to conceive, right? At certain times of your cycle. And so if you're not timing it for when you're most likely to conceive, there's that piece of information, that education is really important to understanding how to help you meet your goals for conception or for not for avoiding conception. Um, right, all the screenings, and then health maintenance and promotion. So those general kind of screenings, blood pressure, we catch people, wow, you're developing hypertension, but if you do some things now, you might be able to like back away from that chronic illness. Oh, you have, your blood shows that your blood sugar is really high, you're pre-diabetic, but if you make changes now, and I will help you with that, it's not inevitable that it develops into diabetes, but something has to change or you can expect that it will, right? It's starting, but we can back up, but something has to change. So we identify a lot of those kinds of things in our reproductive healthcare appointments that aren't really about reproduction per se, but they are about the overall health. I see this question. How is it possible that someone with PCOS got pregnant without medical treatment? So people with PCOS have irregular ovulation. And so if they finally just had a cycle where an egg actually finally got released it's the right time and the right place is how. So it's always time, like it only takes one time, but it kind of has to be timed well. And so that person happened to have good timing is how that happened. Yeah. Okay. Oh, and vaccines. One of the vaccines I want to make sure to tell you about, and it's not the vaccine that we all know about right now, because of course everyone's like COVID and flu, COVID and flu.
Yeah.
It is the HPV vaccine. This is like, I will get fired from nursing if I don't bring this up right now. So the human papillomavirus, there are over 200 strains of it. This is what gives you warts on your skin, but also you can get genital warts, and also you can get warts, lesions, we call them, which is just any change to your skin on your cervix. And there are a couple of strains that are called high risk HPV that are known to cause cervical cancer, which then makes us understand that cervical cancer is, in a way, a sexually transmitted condition, because if it takes the HPV virus, which you are exposed to from someone else's skin and body fluids, then if we can vaccinate against HPV, it is, in a way, a vaccine against cervical cancer. And so when this vaccine first came out, the guideline is, I want to say it's around 10 to 12 ideally, but it can be as young as 8 or 9. And people were like, why are you trying to give this sex vaccine to my young child? And it's because just like any other vaccine, we're trying to get it in them well before they're actually exposed to the disease. And so if you've ever wondered, why is this coming up in a pediatric appointment? It's because they're trying to help them get access to protect them from those high risk HPVs in particular, well before they might be exposed to it. We can, however, vaccinate even people who are in their 20s, 30s, even early 40s. It might not work as well because you've already been exposed to some strains. But it could protect you from the dangerous strains. And so the HPV, human papillomavirus, is a series of vaccines. It's 2 if you're young when you get them, and it's 3 if you're older when you start getting them. But that vaccine, I really, really wanted to make sure and teach you about. Now I won't be fired from nursing. And I think it was time for the next slide. And I know we're close on time, so I'll try and. Okay, so except for this picture and my like me in my white coat, which are personal pictures, my other pictures come from Pixabay, which is a free online open source images. So that's why I didn't put any kind of reference for them. But this when I was in nursing school, that my daughter's now 8, so she was a baby and she thought it was amazing to listen to my heart. I wouldn't say this is an example of good reproductive health care. She's very young and she could barely talk, but it kind of gets people's attention. So in my book, as a nurse midwife, good healthcare period, but particularly when we're talking about reproductive healthcare, is client-centered. That means it doesn't matter what my plan is based on what I think you're here for, based on what it says in the schedule or the last time you were here. I might be like, oh, looks like she's due for this, this, and this. And oh, it says she wants to talk about whatever. When I get into that office, into the clinic room, my plan doesn't matter. The client's plan does. So it needs to be all about, what are your concerns? How can I help you? You're not here for my benefit. Like, there's plenty of sick people, there's plenty of people who want to have appointments. I'm trying to be here to help you in whatever way you're saying you feel like you need help. So client-centered, trauma-informed. This is very near and dear to my heart as so many of us are survivors of sexual abuse, of sexual violence, and other kinds of violence. We are a vulnerable population, and of course, those of us who are non-white have even higher rates of violence against them. And so trauma-informed care is about the clinician in particular recognizing the likelihood, without having to ask, that the person sitting in that room has been traumatized by something. And it might not even be sexual violence. It could be, migrating. It could be seeing a family member injured, or it could be so many things. But then engaging with them in a way that keeps the power moved toward them instead of toward me. And so that and asking permission, I ask permission to touch people. I do not have a right to touch you just because you are in my office, right? We can use our words, and I can use my eyes and my nose and my intuition to do a lot of figuring out of what's going on. And so that's trauma-informed care. Evidence-based, oh my gosh. So the evidence is changing all the time. And I think that the public has got a taste for that, even just in the last 3 years, because as we're learning about COVID, for example, the recommendations were changing and people were getting frustrated and like, how come now? Because we're always learning. And as we learn better ways to do things, we have to implement them. That being said, it can take 15 years for new evidence to actually get put into practice in medicine. And so you might get different guidance from different providers depending on how up to date they are on the evidence. It also means I'm not just telling you my opinion or like, this is what worked for me. I mean, if you want to know like what worked for you, I'm trying to figure out how to help my baby sleep. Do you have any recommendations? Like, here's a book, here's a study, here's some people. And since you asked, here's what worked for mine, but that was my baby and every baby's different. I do not think it is too much to ask that your provider be kind, gentle, and compassionate. I feel like that's just being a good human. And then shared decision making comes back to client centered and also evidence based and also honestly trauma informed. This is the very concept that I am not here to tell you how to do anything. I am here to provide you with my expertise, my experience, the benefit of my many, many, many years of education, and present the information to you. You are the decision maker. And for a lot of people, they haven't encountered that, perhaps in their lives, but certainly not in their healthcare. And so sometimes it can be sort of like, I mean, I don't know. That's what I came here to see you for, right? So it's like, well, yeah. And so we're going to talk about the evidence again. We're going to talk about, the pros and cons and risks and benefits of various treatment or the choice not to treat, but it's still the client's decision. And I think in the end, you should leave feeling like you are respected, supported, and they understood you, and that your questions were answered. And also you have a treatment plan that you not only understand, but feel capable of putting into action. Because it doesn't make sense. Like, here's one of my favorites. Person who had a baby 3 weeks ago who feels like they're literally unraveling because they haven't slept in the last 4 nights. What you should do is read this book. With what time, right? I got all kinds of book recommendations, but it doesn't make sense to recommend a book to someone who is saying like, I feel like I'm losing it because I haven't slept, right? I can't come up with a plan that doesn't make sense in their life. And so we co-create that plan so that they're more likely to use it. I can do a next slide. Okay, I can do this one pretty quick because it'll be nuts and bolts. Pap smear timing. So Pap smear is the test where we screen for cervical cancer. We have to do a pelvic exam, which means putting our fingers inside of the vagina. And that's to help us locate the cervix, feel if the ovaries feel like they're larger than usual, and determine the angle and position, basically the position of the uterus. And then we insert an instrument called a speculum, which is the like duckbill thing that if you've had a speculum exam before, you know very well. And that holds open the vagina so that we can see in with a nice bright light to look at your cervix. And there are some things we can tell are going on just by looking, but with cancer, we need to actually pick up some little cells. And so we use something called a cytobroom, which has a long handle. So that part, if you've had a speculum exam where you're like, what is that? It's this like deep, uncomfortable feeling because the cervix does not like to be messed with. And we're like sweeping this little brush around it to try and pick up some cells. We send them off to the lab. Someone looks with a microscope and says, this is unremarkable. There's no cancer, which is good news. It is important because that's how we screen for cancer. It's recommended for everyone with a cervix, age 21 to 65 years. When you're in your 20s, the recommendation is every 3 years, as long as you continue to have normal results. How frequently we do them depends on what the results are of each one. And then in your 30s, we introduce a second screening with it called co-testing, in which we can also use that same brush picks up cells that they can at the lab look and see if you have one of the high risk HPVs that I talked about, that vaccine. And if that continue, if you have normal cells and no HPV, you get 5 years between speculum exams. And then after the age of 65, if everything has been normal and you haven't changed partners or just behaviors, then you don't really have to keep doing them anymore. Mammograms are to look for breast cancer. And so I should also preface this with my recommendation is in line with the U.S. Preventive Task Force's recommendations, and some professional organizations such as ACOG still recommends mammograms in their 40s. And so that is an option. It used to be, they said in your 40s, and they said like every year, but now we say in your 50s, depending on your risk. So if you have a first degree sibling with a first degree relative, that could be a parent, a sibling, a child with breast cancer, you have increased risk of breast cancer. And so you may prefer to start screening with a mammogram every 2 years in your 40s. But if you don't have that risk, it is reasonable to wait until you're 50 and then start screening. The people who benefit the most from mammograms are people in their 60s, because they are, it is, the whole process of treating the cancer is harder because they're older. In your 40s, it's very, very survivable. In your 60s, it's a little bit less so. There's more impact on your life. And so, again, there is not evidence to support continuing mammograms in past 74 years old. So there's your relative risk for having breast cancer based on family and personal history, and also if we find something or not. For women in their 20s, or just people with breast tissue, because men can get breast cancer, we don't do a mammogram first. We do something called an ultrasound, because they tend to have denser breast tissue, and the mammogram doesn't pick things up as well. And so an ultrasound is used instead. If someone finds a lump and they come and see me for a clinical breast exam, so then I feel for it. And then I say, like, it's this big, it feels like this, it's mobile. I list out all the characteristics of it. And then I send a referral for a mammogram, and also they will get an ultrasound if they're 30 years or older. And then, diet and exercise recommendations for healthy reproductive life are the same as for healthy life. Drink lots of fresh water. Almost everyone needs to decrease their sugar intake, their caffeine, avoid smoking. Everyone should avoid smoking. And did I say alcohol? Alcohol is actually really increases your risk for breast cancer, interestingly. And everyday exercise is critical for overall health. And it doesn't have to be a big whole thing with special outfits. You literally can take a walk every day, get your heart pumping a little bit, and it is amazing for your blood sugar, your mood, managing stress. And then building muscle requires some resistance training, which may or may not require special clothes. Lots of fresh vegetables, especially fresh vegetables, the healthiest source of meat if you eat animals as possible. And, fresh fish multiple times a week is very, very good for us. The big thing is minimal sugar. Sugar really does awful things inside of our bodies. I think with what to look for in a healthcare provider is all the same things I talked about for what does good reproductive healthcare look like, in that if you look for those things in a person's bio, then at least they are aware that those are things, right? Like my bio says, Arya's practice focuses on client-centered, evidence-based, trauma-informed care for everyone, except people who were born men and still identify as and children. So you can look for those little hints that it's a person who's trying to provide care in that way, who is at least aware that that is the goal. And the last thing I really wanted to touch on, and I'm sorry we don't have a little more time to go in more detail, postpartum changes. Everything. Everything is different. But one of the things I want to really take a moment to say, because it's so important, is that the risk of depression and anxiety when we are pregnant and postpartum is increased over any other time in our life, partly because stress is a huge cause of those things. Psychiatric illness increases the risk for you not gaining enough weight in pregnancy, for having a baby that didn't gain enough weight while it was growing inside of you, growth restriction, meaning it's like it didn't grow as big as it would, not just weight wise, miscarriage, and preterm labor and birth. And we're more likely to have, especially depression or anxiety, in pregnancy than we are all of the other complications of pregnancy combined. That's huge. So we put a lot of focus in healthcare on like screening for gestational diabetes and screening for hypertension and preeclampsia, and all of that is important. But the people who are impacted by depression and anxiety far outnumber all of the people who have those other things combined. And so if you're sitting in your prenatal appointment and they're like, how has your mood been lately? How much have you been affected by feelings of hopelessness and lack of interest or energy? They're screening you for depression, and that's really important. And if you're having trouble, please, please, please seek help, because it impacts not only you and your health, but the health of your baby, the health of your family, and the health of our communities. It really is true that most of the healthcare of a family is decided by the mother. And so if we can help the mother figure be as healthy as possible, and especially in any mood conditions, it's going to help everybody be healthier. There you go. Phew.
Is there one more slide, or is that the last?
It's like the contact slide. So yes, the last slide is how you can find us. We should show it so that people can see it if they need anything. So I put our clinic information on the left-hand side, our website, how you can email for information. We have a clinic and birth center in Renton, and we have a clinic and are building a birth center in the Hillman neighborhood, right there in like Rainier Valley area, in Seattle. And then if you want to get more me, if you want more Arya, you could definitely call the clinic and make an appointment, but also you could visit my website and see more about my practices. Instagram and Facebook are there. It's been a little while, but I like to do little educational, like 10-minute videos on a number of things. And you also can watch my process recovering from COVID this spring, which was phenomenal.
Wow, thank you so much for coming on tonight, for making this wonderful presentation. For those of you watching who have taken my childbirth class, I hope that you heard a few of the things that I've talked about in class. And just in case you didn't, I will read you off my short list that Arya touched on. Client-centered care, having trauma-informed care, CNMs and where they can be found, shared decision-making with your providers, how depression, mental, spiritual, holistically, it's important for our health to make sure that we are paying attention to that, and that you should seek help if you are feeling depressed and anxious during these times. So once again, I want to thank you so much.
It was such a pleasure.
The information was amazing, and I'm sure that when we have you come back, wink, wink, because I definitely want more of Arya. Great information, just like tonight. I thank you so much. Really appreciate it.
You're so welcome. I'm very honored to be here, and just thank you so much for trusting me to share this information with you.
All right, everybody, we will catch you next month with our next talk story topic. Stay on the lookout, and thank you. Have a good night.
Good night.